Okay, right. Am I still audible? Okay, great. So thank you very much, everyone, and great evening to you all for joining in this yet again weekly webinar series organized by the Zambia Medical Association. Just a reminder that as part of professional development, the Zambia Medical Association had pioneered this weekly webinar series with the emphasis to not only ensuring professional progression and development, but also empowering our members with up-to-date management of the more common conditions. Now, the theme for this series has been anchored towards the 10 causes of mortality in our country. And I think the neonates have been appearing on such a list. So this evening, we are graced to have our expert speaker, who's going to be Dr. Kunda Kapembwa. She's a pediatrician and neonatologist that is currently working in Zambia. So she holds a bachelor's degree in medicine and surgery, as well as a master's in pediatrics and child health from the University of Zambia, and certified Master of Philosophy in Neonatology from the University of Cape Town. Dr. Kapembwa's career, is dedicated to the health of the neonates and, of course, their families, as well as nursing and the doctor's education in the care of this very special class of citizens called the neonates. So she's currently the honorary lecturer at the University of Zambia in the School of Medicine and also the School of Nursing. And she's involved actually in quite a number of training sessions, as well as training neonatal nurses. She's the current convener of the Postgraduate Diploma in the Neonatology program in our country under the Colleges of Medicine and Surgery, abbreviated as ZACOMS. Dr. Kapembwa co-founded the Newborn Support Society of Zambia, which is a non-profit governmental organization that is aimed at improving the care of neonates in our country. So this evening, we're also graced to have Mr. Maxwell Sichilongo, who is a banking and mortgage expert. As you all know, this webinar series has been sponsored by the Zambia National Building Society. So later on, Mr. Sichilongo will just come through to tell us a little bit about what their products would be. But with these few words, I would just like to invite Dr. Kunda Kapembwa to go straight into our didactic discussion for this evening, which is the care for premature neonates. I'll be your host. My name is Chuma, on behalf of the Zambia Medical Association Executive. Dr. Kapembwa, it's all over to you. And maybe just a reminder to the participants that you will be able to ask questions through the question and answer session that will be opened after our two speakers. But if you still have a pressing question, you can drop it in the chat box or wait to have the session opened and verbally ask. It's over to you, Dr. Kunda.
Sorry, Chuma, sorry to interrupt. There's some people in the waiting room.
Okay, thank you very much. Good evening, everybody. Thank you for the kind introduction. So caring for premature...
Hello, Dr. Kapembwa, can you hear us?
Yes, I can. You can't hear me?
We can hear you.
Okay, all right. Okay, so I was just saying that caring for premature neonates is a subject that is very close to my heart because I think we... Hi, Chuma, maybe it's you. Gay, can you hear me?
Yes, I can hear you clearly. I'm able to hear you.
Can everybody else hear me? Okay. Can everybody else hear me? All right.
Yes, you are loud and
Dr.
clear.
Kapembwa, can hear you.
All right, thank you. Okay, so I think we'll get right into it so that we try and save this preterm baby. And I was just saying that they're close to my heart.
Kapembwa, can you hear us?
Yes.
I think we have a bit of a technical challenge there.
Okay.
The rest of us are able to hear you. Let me just try and message Dr. Njovu.
All right. Okay, so I can go ahead.
Yes.
All right. Okay, so premature babies are usually not given a chance. And so when we talk about premature babies and we talk about how big the problem is, I really don't like discussing statistics because I think half the time you even forget the numbers that one would have said. So on this slide, I'll just tell you that in our country, we have at least 100 babies dying every week, and over half of these are actually premature babies. So we are saying that if we had 10 babies being born, at least 5 to 6 babies would be premature and they would actually die because we didn't probably give them a chance. So when we talk about preterm babies, we're really talking about those babies that are born before 37 completed. Now, this is very crucial because a baby gets most nutrients towards the end of the 3rd trimester. So if a baby is born prematurely, they would have missed out on certain goodies that would be good for their body. So when we are defining premature babies, we'll actually use either weight or gestational age, in which case, if a baby is less than 1 kilo, there'll be extreme low birth weight. If they're between 1 kilo and just less than 1,500 grams, there'll be very low birth weight. And those above 1,500, but less than 2,500 are low birth weight. But please note that low birth weight infants are not all born preterm. You can have a baby who's born preterm, but they are actually low birth weight. And please just note that these will also have problems. When we look at definition of gestational age we look at preterm babies by gestational age, we're looking at the number of weeks. If a baby is born before 28 weeks, they are said extreme preterm. In our setting, the age of viability is 28 weeks. So when you have a 26, 27 weeker, you really start asking yourself how much chance you should give that baby. Do you have what is required? So you find that even when you look at the statistics, most of the entries for the DHIS, HMIS will actually start from 28 weeks or 1 kilo. This still remains debatable because apparently WHO was recommending 26 weeks, but do we have the resources required? So that then as we go down further, we see that there'll be very preterm, moderate preterm, and the babies that are late preterm or moderate preterm are more likely to die because these ones may be the normal weight, 2.5 kilos, but they are still immature. Their physiology is still immature. So you find the mother goes home and says this baby is actually not breastfeeding, sleeping most of the time. The baby looks jaundiced. It's all because this baby is actually preterm. When we look at the risk factors, really it's the maternal and fetal factors, and mothers who are at extremes of age, less than 18, and those that are above 36 are more likely to have preterm births. And those with medical conditions, this week people have been talking about sickle cell disease, and this disease is actually quite devastating, especially during pregnancy stage. So if one has a medical condition, they really have to be prepared prenatally before they can actually conceive. Then there are issues like infections. Then you have fetal factors. Chromosomal abnormalities are more common in those women that will actually have recurrent miscarriages. So if they do have recurrent miscarriages, look at their genetics. Okay. Then, so basically, all preterm babies are at risk. And the more preterm the baby is, the more you have to jump to actually save them. But if you give them what they need, it doesn't even need to be high-tech. You find that these babies are actually able to survive. These are some of the few signs. I won't go through the whole list, but I've put these specifically because we'll speak to them on the next slide. The things I want you to note here are the thin skin, which is shiny, and this is actually quite porous, allows this baby to lose more heat than necessary. They have very little body fat, so they have no ability to break down fat to keep themselves warm or to actually increase their blood glucose. Then the biggest issue is a preterm will have problems feeding, and then there'll be a very problem baby to cannulate. So this actually becomes a challenge, and in which case health workers should actually learn to even put an umbilical catheter, because they are most definitely going to have feeding problems with an uncoordinated suck and swallow. So you may find that you have an extreme low birth weight baby, and to go and try and feed them by cup. They don't know whether this feed should go in the esophagus or it should go in the trachea. And half the time it will go in the trachea and they are going to choke. So anticipating that there'll be feeding problems is good, because then we know whether we have to insert an OGT or not. Suffice to say, if a baby is less than 1.5 kilos, please insert an OGT or a nasogastric tube. So these are some of the problems that I alluded to in the previous slide. The preterm babies tend to have poor temperature control, so they'll get cold even faster. Firstly, they have that thin skin that we talked about, and then the less body fat, making them have fewer reserves. And they are more likely to have problems breathing, especially if they are born below 34 weeks. Their lungs are immature. They have inadequate surfactant. I've already alluded to the feeding problems and the issue of infection. Anticipate infection. In a woman who comes in spontaneous preterm labor, it's assumed there's a septic risk because this baby is supposed to stay in. So the assumption is maybe there's an infection that has actually caused, the prom, and this baby is actually born before time. So there's an infection risk. They are more likely to be jaundiced, anticipate jaundice, and feed cautiously because they may have NEC. I won't go detailed here because I think that antenatally we know what we're supposed to do to actually check, the gestational age. I'll just say here that most of our women actually don't do an early scan, which is going to date this pregnancy adequately. Most of them won't even remember what their last normal menstrual period was. So in our setting, when you look at that definition, it becomes very difficult to define prematurity using weeks. Then when the baby is born, the most important that we have to learn today, if we haven't learned it, is the foot length. So with the foot length, you measure that foot with a caliper, and if you look on the chart here, you'll find that the foot length can be extrapolated to the gestational age. This is easy to use. I think it's much easier than even doing a Ballard score that will involve a lot of things. The maturation assessment, which has neuromuscular activity as well as physical activity. So take home today, let's learn to do the foot length because it's the easiest to do. Even midwives can actually be taught. We can have this little chart in our labor ward. Then this is a Fenton chart. The premature babies will go to the under 5 clinic and they'll be given the card that is meant for a term baby. So every time you see they've plotted their birth weight, it will always be below the road to health. So the Fenton chart actually takes into account the gestational age at birth. So when your baby is born, like we've said, we don't know whether the mother did an early scan, we don't know the gestational age, but you do your foot length and you are able to actually, estimate that, okay, with this foot length, maybe your baby is 32 weeks. So then you're going to plot your weight. You have to check the head circumference and you have to check the length. When you plot this, you have to be plotting weekly. It's important for us to note that the head is actually increasing because this is showing that the brain is growing. So this little Fenton chart can be used until the baby is 50 weeks, and then they can actually now move on to the correct under 5 card. So when we talk about preterm babies, I think now basically we are starting our lecture. Preterm babies have a higher rate of mortality and morbidity as compared to those that are more mature. And like I said, the more immature, the more complications and the higher the risk of mortality. I like to describe these complications in the most practical way so that we will know what things to look out for in the first 24 hours. Let's understand what will kill the baby in the first 7 days, what will kill the baby in the first month. When you understand this, you realize that in the first week, you find a baby who has abdominal distension. You will move away from saying this baby has necrotizing enterocolitis because necrotizing enterocolitis usually happens after day 7 of life. So just having an idea of this will actually show you that if you look at the immediate complications, so we're saying immediate complications will kill the baby in the first 24 hours. We are talking about hypothermia, and we've described why. Hypoglycemia, with these feeding problems, this baby may become hypoglycemic, and the issue of respiratory distress, especially depending on their gestational age at birth. Then when you look at the early complications, remember the early complications are the ones in the first 7 days. Most of our babies actually die in the first 7 days. In the first 24 hours, quite a lot of babies die, but in the first week, these are some of the things that will actually kill the babies. Some of these here, the immediate period, will actually continue on and form part of the early complications and will result in this mortality. I'll give you an example of intraventricular hemorrhage. So if you have a very tiny baby, the germinal matrix in the brain is very fragile. So this baby comes out, maybe the baby is not breathing, then you have to resuscitate. If you're going to overbag this baby, giving lots and lots of pressure, this baby is likely to bleed in the brain. And so you have intraventricular hemorrhage, which is occurring as early complications. So these will actually overlap, okay? Then you have late complications, and these late complications are those that will kill the baby in the first 1 month, and you can see that necrotizing enterocolitis is actually appearing here. Metabolic bone disease happens not in the immediate period, but after, like, even 12 weeks, okay? Then look at all these things and understand that you may have anemia of prematurity, iron deficiency. Then you have long-term complications, okay? These premature babies are more likely to even have autism as part of one of these cognitive behavioral deficits. So they fall in that category. All right. We pause a little and talk about this scenario, and I'll just allow 2 answers, then we proceed. And these answers have to be said very, very quickly. So you have a 27-week-old baby. This baby is delivered by cesarean section to a now para 0 plus formal, and she's 41 years old, and she's a non-hypertensive with severe preeclampsia. So what preparations would you do to ensure a smooth delivery and care of this neonate? Just 2 answers.
Yeah, I think maybe they can just unmute and answer. The disclaimer is I won't be part of the...
No problem. Okay.
I'm an oncologist, so I don't want to kill the small babies. My answer is I'm referring to the participants. I've consulted them now. I want them to manage the baby.
Yes, participants, go ahead.
I'm going to pick on, I can see a lot of pediatricians there. Dr. Francis Simusika.
On the spot.
Good evening. Thank you very much. So I think looking at the fact that we are preparing for a 27-weeker, one of the key things that we have to understand is we have to look at what complications we anticipate this 27-weeker to have. So first of all, the OBS team, as well as the pediatric and neonatology team, needs to discuss the case. adequate preparations to ensure that the theater space will have a neonatologist on hand to handle all the matters to do with resuscitation, plus minus intubation, should it need to go there. So we will also prepare an incubator in the theater. We'll also ensure that we have our NICU ready for plus minus mechanical ventilation. And in our tray of preparations in theater, we'll also ensure that we have surfactant, just to ensure that we have that extra chemical needed for the lung, and also to ensure that we reduce the respiratory distress syndrome that we anticipate that this neonate might have. So there's things to have in theater, there's things to have in terms of preparation at our NICU, and then also we definitely also have to have an agreement with the obstetricians if they have given some dexamethasone to the mother, just to give us an extra breathing space to ensure that we reduce some of the complications we anticipate, like respiratory distress syndrome. That's my short form answer. Thank you.
He's answered everything. Thank you, Francis.
Great. Dr. Kapembwa, I must say that Dr. Simsika doubles as our ZMA treasurer as well. So I can see that he's not only eloquent in money matters, but in his specialty as well. But he forgot one thing: if you see any malignant abnormalities, then you call me.
Okay, we'll do. All right. Okay, so how do I go back to my screen? I'm just seeing, okay, right. I was born in a certain age. So
I think you're already there. You can just slide it.
All right. Okay. All right. So he said a number of things. So when we run through to the next slide, you notice that when we are talking about temperature, he already talked about warm resuscitation. So you want a temperature of 36.5 to 37.5 as normal in neonates. So if you have 36.4, that's hypothermia. It's called cold stress. And we understand that we understand that this hypothermia is because of the thin skin, the low subcutaneous fat, and the immature regulatory centers of the brain. So these are the various ways. And here we'll just look at the practical aspect. When we deliver this baby is wet, and we don't immediately dry, the baby is going to lose heat by evaporation. If we are delivering this baby in a cold delivery room, the windows are open, there will be a draft that will be going. And as the air passes, it actually takes the air, the warmth from the baby. And when we are in a hurry to actually put this baby on the scale, the baby will lose more heat by conduction. And you don't want this. Then for radiation, especially part of the head, if the room is cold, if you have cold objects in the room, this baby will lose heat by radiation. So practically, let's ensure that we have a warm delivery room. And I must speak to the people that do deliveries, especially in theater, that at that point, let's switch off the aircon because we want our baby to survive. Why are we worried? Because the lower the temperature, the more likely that the baby will die. So you've seen, even when we say mild hypothermia, the risk of death increases by 1.8 times. So every drop in temperature by 1 degree increases mortality by 75%. So we need to practice having this warm chain where we have a warm delivery room, a warm resuscitator. If this baby is big enough, above 1.5 kilos, we can dry. For babies that are less than 1.5 kilos, we actually put them in plastic bag without drying them. This is to actually enhance that heat to remain with that baby. Because when we expose and start drying, when they're so small, they'll actually get caught. Then it's also a good habit to deliver this baby on the mom's abdomen. And the baby stays skin to skin with the mom so that the baby can get, warm. There's no hurry in birthing this baby. And really, when you keep the baby and the mother together, you are more likely to win because the mom will know that this baby is actually getting caught. Putting the baby skin to skin will regulate the temperature, will make the baby cry less. The baby won't be stressed. But then also this mom has got all these antibodies, has got all this normal flora that you actually pass on to this baby, and the baby will get this protection that the baby requires. Remember, we are saying that the baby will have very, very low immunity. Antibodies, nutrients pass from this mom to the baby in the third trimester towards the end. So if a baby is born early, the baby missed out on all these things. There's a new concept called IKMC, immediate kangaroo care. This is a scenario where you have this preterm baby who is born. You put on the mother's abdomen. Instead of the way we take away the baby to go and put on CPAP, you can actually start the CPAP with the baby in skin-to-skin position with the mom. This way, you are not making any break, you're not disrupting the transmission of warmth from the mother to the baby. This is evidence-based, and it's been shown that it's reducing neonatal mortality by 25%. In other settings, they've actually started creating what they are calling MNICUs, maternal neonatal ICUs, where if a mom is, still needs care, maybe she's hypertensive or something, she's taken in this room and she's still skin to skin with the baby. The pediatricians or neonatologists go in to see the baby. The obstetricians actually go in to see the mom. This is actually working because the baby actually gets to have all this warmth. The mother doesn't get any stress because she's not wondering where the baby is. She's right with the baby. I talked about plastic bag. This is how you cover the baby with a plastic bag. Put the hat on, don't wipe the baby, and keep the baby like this before you cover the baby. This has been done in a study in India, and it was shown that it actually helps. This picture shows you the color of plastic, the type of plastic. Several times people have asked, what about if I only have a ShowPride plastic bag? Well, it's a plastic. You can put it there as long as it's nice and soft. So warm resuscitation room, and even after the baby is born, keep the temperature 24 to 26 degrees. Most NICUs are very, very hot. I don't know, we cook ourselves, but if you have a wall thermometer, you'll be able to keep the temperature between 24 to 26 degrees and just close the windows, and that will be adequate. And so even after you've delivered this baby, keep checking the temperature, keep ensuring that this baby is with the mom properly in skin-to-skin position. Make sure the feeds have been started. If antibiotics are required, start antibiotics because of that septic risk that we've talked about. So this is KMC position. And basically, you put the baby in between the mom's breasts, and then you cover this baby. It should be comfortable enough for the mother to actually get around and do her chores. Back to our scenario. This scenario is continued. So the baby in the first place was born with a weight of 1,000 grams, and his temperature kept on dropping despite being in an incubator. At a temperature of 33 degrees, it was discovered that, in fact, that incubator was not working. What would you do to improve the baby's temperature? Pick on another pediatrician.
Yes. By the powers vested in me, I think that's the reason why I didn't do pediatrics, so that I can pick on pediatricians. I'm just going to see now. Oh, yes, we've got our chapter chairperson. I forgot she's a pediatrician for Lusaka. The chapter chairperson for Lusaka, Dr. Christina Zulu, please.
Hi, Christina.
Dr. Christina? Okay, as she's ironing a mic, I'm just trying to see who else I can pick on.
Chimwemwe Zulu is a pediatrician.
Oh, yes, Dr. Zulu, there you are.
Hello.
Yes, you see, you can't run away from me.
No, clearly not. Good evening, everybody.
Good evening, Dr. Kapembwa and Dr. Njovu. Thanks for the presentation. Yeah, okay, so things I would do to improve the baby's temperature. So of course, if mom is nearby, first thing I would want to do is KMC. If she's in the room, quick KMC. I would first of all also make sure that this baby is not hypoglycemic, check blood sugars, make sure they're okay. If they are low, I want to quickly handle that because that will also help with the baby being able to maintain the temperature. Then, of course, get the incubator fixed as soon as possible. Yeah, but I think my go-to would be KMC in this case. Thank you. Over.
What if the mom is on the vent? What if the mom is on the vent?
Oh, okay. So if mom is on the vent and there's nobody else nearby, I would put this baby in a plastic, I think, and then wrap the baby up. If there's no dad, there's no grandma. Yeah, I think I'll put the baby back in the plastic and warm the baby up, turn up my heater. We have heaters in that room as well, to make sure the room is warm, make sure there are no drafts coming in from windows closed. Yeah.
Okay. Okay, thank you. I like the dad part. So if dad is there, put the baby on dad's chest. Okay. So remember, we are talking about feeding problems. We've already talked about this. And so just to take you back to this equation, because I need to just emphasize one last time on the issue of hypothermia, because it's one of the biggest killers. So I put these little equations that we did in biology, and we talk about aerobic and anaerobic respiration, just to simplify things. So remember, when you're having adequate glucose, adequate oxygen, you're going to have carbon dioxide, and you're going to have these 38 molecules of ATP, which is required to make this baby survive. In anaerobic respiration, you have minimum oxygen, so you have mostly breakdown of glucose, and you're going to get lactic acidosis, which is going to impair everything, metabolism, and just lead to molecules of ATP. So when we talk about hypoglycemia, we are saying this baby is cold. And because the baby is cold, there's increased metabolism. With increased metabolism, there's increased glucose utilization, and will deplete every little amount of glycogen stores, and this baby becomes hypoglycemic. So when we talk about respiratory distress, it's still about being cold. There's still increased metabolism, there'll be increased oxygen consumption, and there'll be hypoxemia. Then you have got anaerobic metabolism with lactic acidosis, pulmonary vasoconstriction. This is going to worsen the hypoxemia and worsening respiratory distress. So we are saying hypothermia is going to tamper with all this. That explains why these babies actually die. So you look at this baby in this scenario and you check the blood sugar and you find that it's low. To immediately treat hypoglycemia, you have to start your dextrose infusion and make sure that you keep checking, because they will still break down even that glucose that you are giving. This chart is just a guide as to how much fluid you have to give for this baby at a given weight at a given day. And then this also tells you how much feed you have to start. So in part of what has changed now, I remember when I was training as a pediatrician, we used to feed the baby after 48 hours. Now the feeding has to start on that day, if possible in the next 1 hour or two. And this is how you calculate. Other problems are, RDS, wet lung syndrome, it's got TTN now. Remember that the smaller the baby, the higher the chance that there'll be surfactant deficiency, which is RDS. Remember, when you say respiratory distress syndrome, you're specifically saying surfactant deficiency. When you say respiratory distress, it's respiratory distress that can be caused by anything. So respiratory distress can even be caused by a respiratory distress syndrome, surfactant deficiency, just to make it clear. Okay, so we know that, there are certain circumstances of pregnancy that actually result in the babies being born early. So they will have respiratory distress syndrome. And you're supposed to manage them with oxygen. If the baby is not responding, especially if they are small, you're going to start them on CPAP. If this doesn't work, like Dr. Simsika said, you're going to look at giving, intubating, giving surfactant, and actually putting this baby on the vent. So CPAP lecture is a detailed lecture, but just to know that now the world has moved towards delivery room CPAP. Pay attention when using CPAP, because if you give too much pressure, this baby will have a pneumothorax. So we have this baby and we are saying, is this baby needing surfactant? When you have babies that are preterm, sometimes they may just be cold. That's why they're having respiratory distress. You warm them and you find that this baby is actually not improving. You know that you have to either increase on your CPAP or you need to give your surfactant. So saturation targets should be at least the baby saturating between 90 and 95. So that 1 kilo baby in the scenario actually was saturating at 99% at 8 centimeters of water and 5 liters per minute of oxygen. Yes or no? Did this baby need surfactant?
Am I allowed to pick?
Yes.
Did this baby need surfactant? Dr. Msakuzi. Dr. Matilda Msakuzi. Oh, I see she's running away from me. I'm going to pick another one.
Okay, we can carry on so that we save on time. So this baby didn't need surfactant because you can see that already the saturations are 99%. So when you get to this stage, you actually have to start weaning off your oxygen because you don't want to give too much oxygen to the baby. Why not? This is the problem with giving too much oxygen to preterm babies. They have inflammation of the heart, lungs, and kidneys because we were giving like 100% oxygen. They will even have decreased cerebral blood flow. That's why such babies will actually have cerebral palsy because we already impaired their blood flow in their neonatal period. They are likely to have recurrent hospital admissions due to chronic lung disease, but they may also have retinopathy of prematurity. So basically, the motto is reduce O2. And how will you reduce it? If your baby was given antenatal steroids, if the baby has actually been on CPAP, they've been given surfactant, and when you put them on CPAP like this, you find that they will need less and less oxygen. Okay, so when we are giving oxygen, let's give oxygen with love, because retinopathy of prematurity is the commonest cause of blindness, especially in Africa, especially for those babies that were born extremely low birth weight. In terms of infection, please remember the issue of low immunity and assess for a septic risk and give this baby antibiotics because this baby had diminished antibody transfer from the mom. So there are a number of sources. I won't go through them, but as we do our deliveries, let's use aseptic technique. Resuscitate these babies and remember warmth, IV fluids to improve on dextrose, improve the breathing, and that will actually help. Skin to skin is the greatest. So when we're talking about PROM these days, as long as a woman has had ruptured membranes for over 18 hours, this is actually considered dangerous and you have to start antibiotics. Okay. We've been talking about use of caffeine citrate in the recent past because apnea of prematurity is very common, especially for the small babies. But remember that apnea of prematurity is a diagnosis of exclusion. So when you have a baby who's apneic, please, the answer is not caffeine citrate. You have to go through what the causes may be. Is this baby hypoglycemic? Is this baby hypothermic? Is this baby actually having a seizure? Because all these things will cause apnea. And then when you've excluded all these things, then you are going to realize that this may be apnea of prematurity, And as such, you can give them caffeine citrate. Caffeine citrate is the drug of choice for apnea of prematurity. For a long time, we've been using aminophylline, but because we were very behind, now we are actually trying to quicken our steps. It's available in Zambia. It's a little pricey, but I think the more we talk about it, the more the cost will actually be manageable. Okay, so remember that these babies can have jaundice because their liver is quite immature, so they will have lots of, breakdown, but reduced clearance, okay? A ductus arteriosus baby who is stuck on CPAP, has bounding pulses, is not gaining weight, is requiring respiratory support, probably has a duct, so you need to do your echo, and you have to actually discuss with Dr. Mtaja whether this baby needs to have the duct closed medically or duct closed surgically. Yeah. Then we talked about intraventricular hemorrhage. Don't manhandle the babies because they can bleed in the brain, and when they bleed in the brain, you're actually stuck. Okay, so do a cranial ultrasound, see whether the bleed is too big, because if the bleed is too big, it has implication on their long-term survival. They will have issues with developmental survival, in neurodevelopmental care. And neck, remember, best is breast milk. If you have to use formula, yes, you can give preterm formula, but look out for a distended abdomen for a baby with NEC, but only after day 7 of life. Okay, so when we talk about NEC, day 3, this abdomen that is distended could be something else, but not necrotizing enterocolitis. Okay. There are a number of risk factors, but basically, since we share these slides, be able to look at it. I just wanted to emphasize the breast milk bit and the fact that don't make the wrong diagnosis, because NEC occurs at a specific time and there are specific investigations that you're going to do. You're going to do abdominal X-ray, and if you cannot interpret it, ask Dr. Ngongola or Dr. Vulani to actually help. But the pediatric surgeons can actually help you make this diagnosis, and will decide on whether surgery is required or maybe it's just supportive treatment or conservative management. Okay, so our baby had abdominal distension on day 10, and I think I've already described what this may have been. So you keep NPO, make sure that you keep your NGT open for decompression, and do your X-ray. Start your IV fluids, ensure the blood sugar is actually normal. Anemia, preterm babies are more likely to have anemia. Obstetricians, please try and do delayed cord clamping when you deliver preterm babies. You can do delayed cord clamping for 1 to 3 minutes, and but if the baby requires resuscitation, this will take precedence. You can cut a long cord so that we can do cord milking. But for babies that are less than 28 weeks, don't do any cord milking, because this has been shown to cause hemodynamic instability. Okay, so these are some of the causes of bleeding, and I think you guys can go through these slides. Okay, so we've talked about delayed cord clamping, we've talked about the benefits, and remember we said that they will have anemia. So if you do delayed cord clamping, the need for a blood transfusion is actually reduced. But also when you do delayed cord clamping, you're allowing that blood that was in the placenta to actually go into this baby, and this increases the circulating blood volume. So your baby is going to settle very, very quickly. Okay. We talked about metabolic bone disease. We've talked about giving oxygen with love because of the issues that you're going to face. Okay. So I heard a story of this couple that was arrested because they found that the baby was dead. And I think it was assumed that the mother had slept on the baby. So I think when you hear that, ask the story. The question, was this baby preterm? Because preterm babies are likely to die of sudden infant death syndrome. It's more common in this age group, especially if they were on oxygen for a long time. You just find the baby dead. So because we anticipate this, when mothers are going home, we need to tell them, please don't nurse your baby on the tummy. You put the baby on the back. We are calling it back to sleep because this is actually life-saving. I think in a nutshell, babies that are preterm are likely to be in hospital recurrently, but this eventually passes. When you discharge them, emphasize on continued KMC at home. Emphasize on, yes, the baby will breastfeed, but when they stop breastfeeding, it's not because they are full, but it's because they are actually tired. So they should give top-up cup feeds. Then iron supplements are important. Start immunizations immediately after discharge. A lot of babies get turned away because they were too small. Small for what? The babies need the vaccines more than even the 10 babies, because remember, we are saying they didn't get the antibodies from the mom. It's the same dose. You don't even have the dose. Give the dose and then continue following up these babies. Okay. This is my last slide, but before I stop, I need us to just discuss this. And I think that this will be best answered by a pediatrician. At 6 months post-delivery, the mother returns to the hospital because she's worried that the baby is not yet sitting. So this is the same baby we've been talking about, who was born at 27 weeks. This baby needed CPAP, remember, needed KMC, and now we were at a point of discharge, and we've already discussed that this baby should receive immunizations, and that was done. But then at 6 months, the mother returns to you because she's worried that the baby is not sitting. But the baby is feeding well and gaining adequate weight. What do you think is going on with this baby? Are you worried about this baby? Chuma, one last time, one pediatrician.
Yeah, I'm scrolling through my my pediatrician list. At this moment, I'm excited not to be a pediatrician because I'm immune of these questions. Okay, so we're gonna get back to I want to pick on Dr. Mumba. Dr. Mumba Chivesa.
Dr. Mumba Chivesa.
Yes, you can just unmute yourself.
Hello, can you hear me?
Yes, loud and clear.
Okay. So I wouldn't be worried about this baby because this baby was born early. So the baby was born about 13 weeks early, and the mom has come at 6 months chronological age. So corrected age, the baby would be about 3 months. So you don't expect a 3-month-old to be sitting. So I wouldn't be worried. I would just reassure the mom. Thank you.
Great. So we correct the age. Every time they come, we correct the age. So the corrected gestational age is 40 weeks because we are supposed to be at 40 weeks, right? That's when the baby is supposed to be born. But if the baby is born at 27 weeks, we have 13 weeks more to go. So these 6 months, which is 24 weeks, we subtract 13 and we find that the baby is actually very small. Okay, thank you, Dr. Chivesa. So basically, when we talk about the current trends, we are emphasizing on antenatal steroids because we want to mature the lungs. We are now talking about magnesium sulfate for neuroprotection. Okay, the obstetricians, I'm glad, are buying in and actually giving Maxwell for neuroprotection. We are talking about delayed cord clamping. And then we're saying a warm delivery room, and you start CPAP in the delivery room. Okay, be wary of how much oxygen you give here. Then we're talking about IKMC, where there's immediate kangaroo care. We're talking about caffeine citrate for prevention and treatment of apnea of prematurity. If the baby wasn't coping on CPAP, we would actually give them surfactant. And when we start talking about giving oxygen, it's oxygen with love. In other places, they're giving probiotics. I think we should start this as well. And then we need to start feeding early. Feeding early is a bit challenging because moms to to preterm babies may not have breast milk, especially on the first day. So we should start thinking about having breast milk banks in Zambia. I don't think it's that hard. Thank you so much. Yeah, I know I've gone above time. Thank you for your patience.
Thank you, Dr. Kapembwa. I mean, you haven't really gone beyond time. This has been a very exciting talk. I mean, I'm not a pediatrician, but I've learned a lot. And I feel like I've just revamped my pediatric skills. I think the next time, just throw me in the neonatology ward, and your neonate is going to be set. That I can assure you.
You don't joke like that. We'll do it tomorrow. Francis, what do you think?
Let's send him now.
We'll give him a ward round.
Well, certainly, especially that it's winter, I would want to be in that warm environment. So right after this talk, you see me in those orange. And why do you use orange gowns?
We don't use them anymore.
Okay, all right.
We
Yeah,
haven't used them for years, Dr. Njovu.
He clearly
Perhaps
needs to go
it's
back
just
to
showing how
meetings.
many years I've been in practice, or I've been away from people.
Okay. Thank you, Dr. Njovu.
In mind and in talk, just a reminder, this has been the ZMA online webinar series, and today's talk has been Care for Preterm Neonates. Remember, the series has been themed under the top 10 causes of mortality in our country. And this week, we're blessed to have our expert speaker, who's the specialist neonatologist, Dr. Kunda Kapembwa. I just want to take this opportunity to also acknowledge the presence of some ZMA executive members. I've seen we've just been joined by Dr. Oliver Kaoma, who's the current Secretary General. Dr. Francis Msika has been very patriotic in this session. I think it's just underscores his passion for pediatrics. And of course, a lot of you ZMA members and some of the senior colleagues that joined in. At this particular time, we're going to open the question and answer session. And fortunately, we just got word that Mr. Sichilongo will not be able to join us, but we just want to thank them for having sponsored this session. ZNBS has been a very great partner for Zambia Medical Association. They are promoting this professional development and ensuring that our members acquire this up-to-date knowledge and scope of this practice. At this particular time, if you've got any question, you can just raise your hand with the emoji and then just pick that. I can see the chat box has a lot of questions. Dr. Kapembwa, it's not me. I think these questions are to you. Of course, they want some slides. Yes, she'll share the slides and we'll be able to share with you members. Okay, it looks like most of them are just answers, but let me see if we've got a hand. Yes, we've got a hand from Pauline. Pauline, you can just unmute yourself and answer the question. And then Letitia. So we'll take 3 sets. Pauline, unmute yourself. My very good colleague and friend, Letitia Mwinga, you can also ask just after Pauline. We will take a set of 3 questions and then Dr. Kapembwa will answer them and then build it up from there. So I think Pauline first. Pauline, you can just unmute.
Okay. Thank you. And thank you, Dr. Kapembwa. Wow, learned a lot. Can you not hear me? Can you hear me?
We can hear you now.
Can you hear me?
Yes. We can hear you.
Hello?
Yes, Pauline, go ahead.
Ask the question. We can hear you. We seem to be having a technical challenge with Pauline. Maybe Dr. Letitia Mwenga can proceed with her question, and then we'll get back to Dr. Pauline thereafter.
Thank you very much, Dr. Njovu. Dr. Kapembwa, thank you very much for the presentation. It's always a pleasure listening to you. We always learn something. I just wanted to ask, or maybe ask for your comment also pertaining to feeding. Rather, at what point do you say this preterm baby has malnutrition? Following what we've discussed on a baby who comes at 6 months and they are not they are not sitting, are you going to be worried? What about the issue of nutrition and malnutrition? At what point would you say this preterm baby has malnutrition, or when should we be worried? Thank you.
Okay, I'm getting another question, or should I answer this one?
Yeah, I think you can answer this one as we wait for other questions to get through.
Okay, thank you, Letitia. So when we are talking about malnutrition in preterm babies, remember that you want, especially in the early days, you want the baby to gain 15 to 30 grams per kg per day. By the time they are actually getting to term, around 40 weeks, you expect that they should be around 2.5 kilos. In which case now we are going to move to your normal under 5 card. And from the normal under 5 card, you actually be able to see, the road to health chart. Is this baby growing the way they should? And it's also important to note that there's a lot of stunting that happens in preterm babies, especially if we don't give them all the supplements. If you're going to talk about 6 months, you should be talking about them as if they were term babies, because they should have actually caught up. So malnutrition will be defined the same way you're going to define malnutrition in a baby who was born term, especially after the first few months of life. Does that answer your question?
Yes, Dr. Kapembwa, we still have quite a number of questions in the chat box. I think I'll read the first two to you. The question from Dr. Manea Nabwende is that, are we encouraged to switch to formula if the mom is unable to produce adequate breast milk days after delivery? And then the other question is, are there guidelines from in utero transfer for facilities without NICUs?
Okay, thank you very much for these questions. So, that's why I even made the comment of having breast milk banks, because unfortunately, the NICU is one of those places where we mixed feed, because moms will just not produce milk, and you don't want this baby to stay for a prolonged period of time without feeding. Babies who are not fed early are more likely to develop necrotizing enterocolitis. So you're going to look for preterm formula, and you're going to start feeding this baby cautiously. Unfortunately, if we had a breast milk bank, then we would just get consent from the mom and we would start feeding in the first few hours of life. In terms of guidelines for in utero transfer for facilities without NICUs, yes, in the maternal neonatal referral guidelines, we actually put some of these guidelines there. If you are anticipating you have a high risk pregnancy, you are more likely to suspect that this baby may need respiratory support, may need NICU care. So the best is for you to actually arrange a very quick in utero transfer, and when the baby arrives in that facilities, the obstetricians should actually be in communication with the NICU team so that this baby is started on, what is required very, very quickly to save this baby's life.
Right. Fantastic. You see what I'm saying? That after this talk, throw me in the neonatology ICU, and your babies will be safe tomorrow morning. Okay, so we can still take another set of 3 questions. You can just raise your hand. Dr. Pauline, are you able to get through? Or you can just type your question in the chat box, Dr. Pauline.
Oh yeah, I typed it. That was the one about in utero transfer.
Okay, perfect. Great, great. Anyone else? I see that we still joined by other neonatologists as well. Dr. Gay Mundundu is on the call. We just want to take this opportunity to congratulate you on such the great success. Perhaps you can just greet the members.
Thank you very much, Dr. Njovu, and good evening to everyone on the call. Yeah, I've enjoyed the talk. You can never learn enough about neonatology, and who better to learn from than the guru herself.
Great. Indeed, colleagues, that was Dr. Gay Mundundu, our newly qualified pediatric neonatologist. Okay, Dr. Simsika, do you have any final words to say?
Good evening. I think there's
Oh, yes, there's a
something
question.
in the chat.
Okay, let me just read that quickly. So this question is coming from Dr. Yusuf Ahmed, and the question is, comment on the follow-up of auditory ophthalmic neurodevelopment deficits that will manifest later.
Thank you very much, Prof, for this wonderful question. Unfortunately, we seemed not to have really followed up on having babies have a structured approach towards follow-up in terms of hearing screening and eye screening. And Prof, we've recently published a preterm under 5 card, which actually highlights, it's actually a resource for moms, and it actually highlights when the mother should actually take the baby for screening, for hearing screening, because if a baby is born below 32 weeks, by 4 weeks, we should really be checking their sight. And we should be checking their ears, and we don't do this. And I think hearing screening is something that is very, very easy to do, because in other places, actually nurses tend to do this screening. We just need to train them. So yes, this is something that we have to emphasize. I think Prof has also talked about the emphasizing in his previous comments, prenatal aspects of use of antenatal steroids, mode of delivery. These need to be emphasized for sure. If there's any suspicion of sepsis, then there's this withholding of antenatal steroids. And the discussion is, at which point do you actually want to give these steroids so that you can see a good outcome in the baby? We need to continue having this discussion, and I think that we need to continue having the discussion regarding giving Maxwell for neuroprotection. Thank you, Prof.
Great.
Sorry, I think he has another question.
Yes, there's like a follow-up question to that.
Yes.
And he's basically asking on the cooling.
Cooling, yes.
So
cooling basically, Prof. Yeah. So Prof is referring to a treatment for babies who are asphyxiated. We call it therapeutic hypothermia, or indeed cooling. So this cooling has been shown to have a beneficial effects for babies who were asphyxiated. At 18 months, they are said to, develop more, better neurologically as compared to the other, other cohort. They did a number of studies, the Toby trial, the Kuhat trial. But then there was a recent study that was done in Africa, and it showed that in resource limited settings, it's better not to cool, because therapeutic hypothermia is labor intensive. It requires specialized equipment. It requires monitoring. And if we are not able to do all these babies are more likely to die. So it's been agreed that cooling should only be done in a setting of, a study where everything is actually optimized. Thank you, Prof.
Great. You see, I keep learning, and the more they ask, the more I pick up these neonatology skills. I can rest assure you that your babies will be safe tomorrow morning when you leave me there. Dr. Kapembwa, we got another question coming from Dr. Monde, that you talked about early feeding. Do we have any protocols on which preterms should be initiated on feeds in the first 24 hours?
Yes, we do. And all preterms should actually be fed in the first 24 hours. The only challenge we have in our setting is, do we have breast milk to give on the first day, especially for extreme low birth weight babies? If we did have breast milk banks, you just put your baby on CPAP, this baby stabilizes. In the next 2-3 hours, you are actually feeding. So you start with small feeds, and as the baby tolerates, you actually increase. We have this in our neonatal protocol.
Fantastic. All right. Any other questions?
I think there's Charity.
Charity. Oh, yes. So Charity, Dr. Charity is trying to find out, how do you prevent chronic lung disease in the setting where there's no surfactant and you only have CPAP?
So CPAP has actually been shown to reduce the, even the severity of chronic lung disease. So in a setting where we may not even have surfactant, here we even have to anticipate preterm birth, give antenatal steroids, because antenatal steroids will improve surfactant production. Antenatal steroids are going to reduce the incidence of intraventricular hemorrhage. Antenatal steroids are going to reduce on necrotizing enterocolitis. So we emphasize on the things that we can do, because those are actually low cost but high impact interventions. Otherwise, give your CPAP and make sure you give the, optimize CPAP. Unfortunately, sometimes you may not even have CPAP. Make your little Pemani. It's better than you just giving oxygen. Pemani is a little bottle that we make that generates, a bit of pressure and allows the baby's lungs to expand. I think maybe we just have to use what we have. That would be my answer to that.
Okay, there we go, Dr. Charity. So we work with what we have, which has been what we are best at doing in Africa. We are always improvising. Great. I mean, I must say, Dr. Kapembwa, that from the time we started this webinar series, this has been the most interactive session that we have had. And we can see that there's indeed a lot that you can learn and talk about the care for the preterm neonates. I'm not just sure if I've missed out any other questions. I think if there be no other questions, I'll just allow the Secretary General for Zambia Medical Association to just thank the members for joining through the webinar. And then I'll invite you to just give your closing remarks. And then we'll eventually thank Dr. Simusika for having made sure that we had sponsors for this webinar series. In that order, Dr. Kauma.
Good evening, Dr. Njovu. There isn't much for me to say. I just want to acknowledge the presence of the senior members of the profession and commend Dr. Kapembwa. As always, it's gratifying to hear and learn from her. And also to commend the members for having stayed up to listen to this insightful and educative webinar. Additionally, I would like to commend your office, Dr. Njovu, for having been very passionate in pushing for this series to commence. So to you and your team and the rest of the profession, I just hope that we can find more resources so that we can have chapter-focused webinars so that people can actually learn and improve the health outcomes of our preterms. yeah, so thank you very much, and commendable work.
Thank you, Dr. Kauma. That's our Secretary General for the Zambia Medical Association. It's Dr. Simsika, and then Dr. Kapembwa will close the session. Dr. Simsika.
Thank you very much once again, Dr. Chuma Njovu, for moderating this wonderful session. And to my mother, Dr. Kapembwa, it's always gratifying to know that you are always willing to teach and to keep on teaching. So this is something that I think is not spoken about enough, to say that medicine is a mentorship and medicine is a continuous process of learning. So having someone who has amassed all this knowledge just be able to give herself and just teach and teach and teach, I think we just have to say, hopefully we are able to give you your flowers every day that you are with us. And my twin, my evil twin, Dr. Gay, congratulations. I'm saying this on on a public forum, but I will also be able to give you something in the background. So congratulations for achieving why you are twin one. So kudos to you, and I think a step in the right direction for not only the Zambia Medical Association, but also for children everywhere. So thank you very much. And to everyone who has joined, please do continue joining in. We are dedicated and we will find resources. It's just a matter of writing concept notes and just pushing the agenda. So thank you very much for joining. Good night. Thank you.
Great. Thank you. Thank you, Dr. Simsika. Dr. Mundundu, we are witness to that. If you don't get your parcel, just hire me. I know what to do with them. Dr. Kapembwa, so preterm complications have been listed as the 4th leading cause of mortality in our countries. What would be your advice to the practitioners in trying for us to scale down on this mortality rate?
Thank you very much for all the kind words. And I feel that my life is purposeful because I feel that I reproduce myself in my children. Yeah, so I think that in the case of prematurity, it's actually preventable. First, we have to prevent preterm births, but if we can't prevent them, we can do the small, simple things that are highly impactful. Skin to skin, breast milk, CPAP, and I think for me, antenatal steroids is just a winner. So the things, we shouldn't focus on the things that we can't do. Let's focus on the things that we can do to send these babies home. And I can tell you that it's very doable. Thank you, ZMA, for this opportunity. And yeah, good night, everyone.
Fantastic. Thank you so much. I think our generosity is on hand to us for you accepting our invitation to lead this session. Indeed, we've been told about steroids, CPAP, antenatal care, and the KMC as the key words in caring for our preterm neonates. I've learned quite a lot, and just a reminder to the rest of ZMA members that this is a weekly series. Next week, we'll be back with yet another exciting topic, and we'll be looking at the common emergence procedures that will be covered by the emergence medicine physician. On behalf of the entire ZMA crew, being your host, my name is Chuma Njovu. We'll be looking forward to sharing another session with everybody. Thank you so much for joining. Thank you, Dr. Kapembwa, for leading this session. It's a lovely night to you all, and blessed evening.